the meeting as much as possible for it. Worst scenario, if I'm not able to do the sessions, the speaker can take up the questions at the end. So flow, as usual, for infectious disease program, the first presentation is done by the speaker, then the posters questionnaire, and finally the Q&A. By 8:30, we can wind up. So if you want to get your attendance, please answer the questions posted by the speakers as well as posters questions and get the attendance instead of just typing your name. Don't type your name. Interact with the speaker and interact with the moderator so that you can get your attendance. Without further ado, I need to introduce Dr. Professor Deepak Kumar. Professor Deepak Kumar is an associate professor, Division of Infectious Diseases at the Department of Medicine's AIMS Jodhpur, and he has got many publications. And is one of the popular speaker. So he's going to discuss today how to approach fungal infections in your practice. This is for the postgraduate level because fungal infections is a difficult topic, and he is the best speaker to solve your approach to fungal infections. I sincerely again thank Dr. Deepak Kumar for agreeing our invitations. The session is yours, sir.
Thank you, sir. Thank you for kind introduction. At the outset, I would like to thank Dr. Suresh Kumar, sir, API and Indian College of Physician to provide me this opportunity to talk on approach of fungal infection, how we can diagnose and manage. So we'll start my talk with a brief introduction about fungus. So these are a very broad classification. You can see fungus could be yeast, could be mold, or could be dimorphic. And mold fungus further can be classified septid and aseptid on the base of microbiology, and dimorphic, and yeast could be candida and so on. But I would like to today's concise my today's talk on some of the fungus. So if we consider clinically significant fungus, or in the as a clinician, I could see the categorized fungus in the two form. One is which are ubiquitous fungus, which are everywhere in the environment, like Candida, Aspergillus, and Mucormycosis, and which are causing very common day-to-day infection in a patients in the ward and ICU and OPD also. And other are the endemic fungus like Histoplasma, Cryptococcus, Paracoccidomycosis. So I'm not going to cover these endemic fungus because they have some specific clinical features and they have some specific diagnostic facilities. But we are regularly facing the infection with the ubiquitous fungus, and how we can approach these three common fungal infection in our ward and the ICU. So I will try to cover these. So again, the same question which I have discussed, that is invasive fungal infection, mainly this ubiquitous, has any specific clinical features? The answer mostly is no. Sometime it could be yes, but most of the time these infections are present as the usual bacterial or sometimes tubercular infection. So what should we do? When should we suspect that patient having the fungal infection? So with the time, what I can learn that when you have in a suspicion of invasive fungal infection, especially these three infection, I used to look these three factors. So when I can able to satisfy all these three factors, then I can say, yes, this could be a case of invasive fungal infection categorized in any of the three. So these three factors are host factor, yani patient has some factor with particular risk for that infection. Is the clinical features are pertaining to these invasive fungal infections, and are our microbiological or mycological criteria or evidences are satisfying that this patient is suffering from invasive fungal infections. So I'll start my discussion with first case, which is quite usual case in the medicine ward. A 62-year male was admitted to the medicine ward with the complaint of fever for 25 days, cough with sputum production for 20 days. And he was known case of diabetes since 10 years, and the recent HbA1c is 8.2, which is quite high. And he is also known case of COPD, has taken multiple type of treatment and multiple hospitalization due to COPD exacerbation. This patient was investigated in the ward, and the CT suggestive of some centrilobular solid nodules with ground glass opacities in bilateral lung field. with some tree in bud appearance. You can see these are the tree in bud appearance. If you can see my pointer, I will try to incorporate the pointer. You can see laser pointer. You can see these are the tree in bud appearance, and these are the centrilobular nodules. And the radiologist has, with mediastinal lymphadenopathy, the radiologist has suggested that patient has some active infection and likely tuberculosis. And I think day in day out, it is not an uncommon to see these type of CT finding in a patients with acute to subacute type of respiratory infection. So what we did, we investigate the patient, hemoglobin is 10, counts is 10,000, ESR and CRP slightly raised, and LFT shows AZ reversal, and viral marker was negative, and patient was investigated in suspicion of pulmonary TB as it was suggested in the radiology, and sputum CB naught was sent and MTB was detected negative. So what should be done next? So as a clinician, routine practice is that if CT is suggestive of TB, we used to start the patient on anti-tubercular treatment even with the sputum CB naught may be negative. So again, I come with the previous concept that we have to look these factors. The host factor and risk factors. So what are the typical risk factors and which infection we can suspect in a patient with the respiratory illness? And what are the clinical features and microbiological evidence? So the original concept of respiratory infection caused by the fungus are came from the hematology or oncology ward. And the common infections which present in these neutropenic patient in the hematology ward or oncology ward is generally aspergillus and mucormycosis. And the typical host factor was considered as invasive pulmonary aspergillosis or invasive pulmonary mucormycosis are the neutropenia. However, with the time, I will discuss there are a lot of non-neutropenic risk factors are arising, and the Mycology Society is also endorsing these uh, risk factor also. Regarding the clinical feature, we will discuss what are the clinical features or clinical criteria that can suggest in our patient that could be a case of either invasive aspergillosis or mucormycosis, which are the common pulmonary invasive fungal infection which can be present. So first, I briefly discuss about aspergillosis. Definitely, aspergillosis is ubiquitous as like mucormycosis, and the disease spectrum most commonly both mucor can cause ROCM mostly, but can cause pulmonary. But aspergillosis is most commonly causes pulmonary aspergillosis. However, extrapulmonary form in the form of CNS disseminated endocarditis and other are quite rare, but invasive pulmonary, chronic pulmonary, allergic bronchopulmonary, these are the common manifestation. And the unique nature of aspergillus is that the type of the disease is depend on the host factor, as we have discussed. If host having a severe immunodeficiency or neutropenia, patient used to have invasive pulmonary aspergillosis. Or if patient is immune overactivity used to present as a allergic bronchopulmonary aspergillosis, or with patient with the normal immune system with some lung pathology like patient with previous tuberculosis, they used to have chronic pulmonary aspergillosis. So it is a unique feature. So how to diagnose the case of invasive pulmonary aspergillosis and how we can suspect similar in our patients. So we'll start what are the guidelines and what are the practices says, what are the practical guideline for diagnosis of aspergillosis in routine practice. If you see the IDSA, if we see the European guideline, or if we see the EORTC MSGRE, as I said, the first concept of these invasive fungal infection is came from the cancer societies. So all guidelines says that these are the diagnostic criteria for pulmonary aspergillosis. Like if we can able to see the fungus in histopathologically, that is only considered as the proven invasive pulmonary aspergillosis. Otherwise, we have to see that patient should satisfy some host criteria, some clinical criteria, and some microbiological criteria, which I have started discussing from the first slide to says that is a case of likely or probably case of invasive pulmonary aspergillosis. So what are these criteria we will see. So these are the actually typical criteria which are the given from the cancer societies that any patients with severe neutropenia, any patients with organ transplantation, any patients more than 3 weeks of corticosteroid therapy, patients on these Bruton tyrosine kinase, especially ibrutinib therapy, and patients with some inherited severe immunodeficiency disorders. So if these host factor is present, then you can suspect in a in like an R case with CT finding, you can suspect it is a case of pulmonary aspergillosis. But these are the quite typical host factors and which is generally not present in the ward, in the medicine ward, the more common in the hematology ward. But if you see the publications in medical mycology, which is quite endorsed by various mycology society, that there are increasing number of non-neutropenic risk factor in cases of invasive pulmonary aspergillosis. And if you see the list of these risk factors, which is quite common in our ward, like uncontrolled diabetes, COPD, CLDs, patient and underwent intracranial surgeries, patient of rheumatoid arthritis, patient of burn, patients using some IV infusions, and patients of allergic bronchopulmonary or asthma. So these can be associated, and these are the newer factors, and these are endorsed by the various society that these non-neutrotic risk factors can be present in cases of invasive pulmonary aspergillosis. And what are the clinical criteria? Here, the clinical criteria is not like the clinical symptoms and the sign, because these type of invasive fungal infections do not have a specific clinical features. So the clinical criteria are considered as basically the CT criteria. So, so what I the first question I raised in the initially, is there any specific clinical features? Yes, if you find halo or reverse halo sign that suggestive of severe necrosis in the pulmonary parenchyma are actually the quite typical sign of the pulmonary aspergillosis or sometimes the pulmonary mucormycosis. So this is basically due to the angio invasion of the fungus. This angio invasion lead to the necrosis, and these necrosis you can see as a halo or reverse halo sign in the CT. But it is a quite typical picture and which is present in not more than 20-30% of cases, and more common in neutropenic and less common in non-neutropenic patient with risk factors. So what are the more common which is can be seen in non-neutropenic and which is not quite typical of these invasive fungal infection is presence of centrilobular nodules, strewn bud pattern, patchy peribronchial consolidation, and cavitations. So our patient already has centrilobular nodules, strewn bud appearance, and some patchy peribronchial consolidations. So these are basically airway invasive pulmonary aspergillosis finding, but it can be present in tuberculosis, it can be present in other chronic or subacute type of the lung infection. And finally, the third criteria is microbiological and mycological criteria. So these are to demonstration of the fungus. If we can able to demonstrate the fungus in the bowel, tissue, or sputum. Basically, the problem with this demonstration or positive culture is the lab contamination. As we discussed, it is quite ubiquitous fungus, and contamination is very common. But even with this, if we can able to demonstrate the fungus or the positive culture with the ball, which is quite good sample, we and patients able to satisfy the host as well as the clinical criteria, we can say it is a case of probable invasive pulmonary aspergillosis. Second is positive serum or ball galactomannan. So I will not go into very much detail with the galactomannan. Galactomannan is an important component of aspergillus cell wall, and it is a marker that if the galactomannan level is increases, it suggests that the fungus is dividing, the fungus is growing. And we can measure this galactomannan level in the serum, in the ball, even in the CSF also, if we are suspecting the CNS aspergillosis. And this presence of positive serum or ball galactomannan, and again it's one of the microbiological or mycological criteria, and the level was more than 1 ODI. If level is more than 1 ODI, it is quite specific. But if patient is neutropenic, then serum uh, uh, galactomannan has quite good sensitivity and specificity to diagnose invasive pulmonary aspergillosis, but if patient is non-neutropenic, like our patient, the serum galactomannan is very poor sensitivity. It's not more than 20-30%, but it is quite specific. However, pal galactomannan, even in a non-neutropenic patient, has a good sensitivity of around 60 to 70%, and but a good specificity to diagnose a case of invasive pulmonary aspergillosis. And third criteria is positive PCR for aspergillosis. Again, the PCR value, there should be a 2 PCR positivity, not 1, because again, contamination is quite common, and galactomannan can shows the fungus is dividing, but PCR does not show. It can show the colonization contamination. So that 2 PCR from the ball sample or tissue sample must be positive to say that yes, we are satisfying the mycological or microbiological criteria. So we have discussed 3 criteria. One is host criteria, which can be present mostly in neutropenic patient, or in non-neutropenic. We have discussed some common criteria, which common risk factors which are present in our ward. Second, the clinical criteria is basically radiological criteria, could be typical halo, reverse halo, or it could be some central lobar nodule, tree bud pattern. It could be patchy periodontal consolidation and cavitation. And last is microbiological criteria in the form of direct demonstration or positive culture from the sample, or positive serum or ball galactomannan. As we discussed, the serum galactomannan is quite low sensitivity in non-neutropenic. However, ball has good, and positive PCR, we require 2 PCR positivity. So we again come to our patient. We did the ball. Again, CB NAT from the ball is also not detected. MTB is not detected. Culture is negative. Ball galactomannan, we found it is to be 1.8, and the direct demonstration shows that fungal hyphae has been seen in the direct microscopy. So again, I'll come to the initial the concept that host factor. So what we can see, our patient is suffering from diabetes, which is uncontrolled, and patient has COPD and already received multiple steroid, and we have ruled out the tuberculosis. If we see the clinical picture, again, tree in bud, central lobar nodule, patchy peribronchial consolidation there. However, no halo or reverse halo in our patient. Or if we see the mycological criteria, yes, bile galactomannan is positive. It is more than 1 ODI, and direct KOH also shows the fungal IP. So I could say, if I have ruled out at least tuberculosis, and we can able to satisfy the host clinical and mycological criteria, so our case could be a case of invasive pulmonary aspergillosis. We started the patient on the injection voriconazole, which is drug of choice for invasive pulmonary aspergillosis. Patient improved and discharged on oral voriconazole. So this is our first case. We will come to the second case. You can see that this is again a 50-year-old male come to the emergency with history of diabetes, which is quite uncontrolled, with fever for 20 days, cough with sputum for 20 days, almost similar type of the clinical picture. And patient received piperacillin, tazobactam, and clarithromycin. You can see the chest X-ray that can show cavity in the middle jaw of the left side of the middle jaw. So we will investigated the patient further. Again, if you can see host criteria, and in our patient, it's diabetes, which is uncontrolled, and X-ray shows some sign. But again, our first differential could be at the bacterial, but patient is not improving with the peptides and clarithromycin, which is received outside, and could be a tuberculosis. And then third differential could be a invasive fungal infections, could be aspergillus, it could be a mucormycosis. So we investigated the patient's counts is high, ESR is quite high, 1110, CRP is very high, 252. Sputum was sent for CB NAT, Z and QH, all are negative, viable marker is negative. And CT, we did CT that suggests patients has an area of consolidation with septation with surrounding patchy area of GGOs and interlobular septation thickening in the left upper lobe, a suggestive of bacterial, and they have also suggested some have probably superadded fungal infection. So we did the BAL of this patient. Again, BAL gene expert is also negative. Galactomannan is also less than 1, but KOH shows broad asepted hyphae, and SDA culture suggestive of mucorales. So same patient with the similar type of the risk factors, uncontrolled diabetes, similar but similar type of the CT finding with GGOs, with some cavitations, with rule out tuberculosis, with not improve with the antibiotics. Again, if we see the major risk factor or host factor for mucormycosis is corticosteroid associate with the uncontrolled diabetes, diabetic ketoacidosis, hyperglycemia, and COVID-19. I think the mucormycosis is mostly came in the picture only with the outbreaks occurs in a patients of COVID who have received steroid and patients already has diabetes. So if patient have a combination of all those three, you must initially suspect the mucormycosis. But if even with the patients with uncontrolled diabetes and DK, patients may or may not receive corticosteroid, but not improving with the effective antimicrobial therapy, have ruled out tuberculosis, you must suspect mucormycosis. So again, I will come with the same concept that what are the host factor in our patients having diabetes, which is quite uncontrolled, our patients CT finding that consolidation, cavitation, and GGOs, which is one of the clinical criterias. And in mycological or microbiological evidence, the direct microscope is also positive for the mucor, and fungal culture is also positive for the mucor. So what I want to say that definitely as a resident, if you get a call from the hematology unit or from the oncology unit, okay, their patient is suffering from fever, cough, sputum production, you must see the URTC MSC criteria. That you have to look patient having some neutropenia or yes, most of patients having neutropenia. Then you have to see the CT finding. If there's a halo, reverse halo, which is quite typical of mucormycosis, and if you patient have consolidation, cavitation, centrilobar nodules, and GGOs, and then you have to send serum and bile galactomannan and uh, this KOH gene expert as well as the PCR to confirm. And when you can gather all these three data, then you can say yes, our case is suffering from invasive pulmonary either aspergillosis or mucormycosis based on these criteria. So I would try to cover basically the common patients which we have encountered in the ward. However, in the oncology, definitely these patients have typical host factors, but in the medicine ward, you may not find a typical host factor like in the form of neutropenia, but many of patients are received more than 3 weeks of corticosteroid, but we do not encounter many of cases which already on ibrutinib and all this therapy. So we can utilize these criteria to reach our diagnosis. So I'll come with my third case. That is a 68-year-old male was admitted in the gastromedicine for diagnosis and management of chronic liver disease. And he is known case of diabetes, and his HbA1c was 8.2. Again, it's high. And our ID team got a call for new onset fever for 3 days, uh, and which was not resolving on the antibiotic. And the WBC shows neutrophilic leukocytosis with mild thrombocytopenia at the HB of the team. So we got the call, our team go and examine the patient, and what they have saw, the patient is on central venous catheter, and basically they not able to get the peripheral line to give albumin to the patients. So they put the patient on in central line to give the albumin. So again, should which fungal infection here to suspect? So what we have discussed again, host factor, yes, our patients host factor having diabetes and chronic liver disease, which is common host factor for aspergillus, mucor, or sometime we're going to discuss the next is candida. But what clinical feature or clinical syndrome you are suspecting in this case? Definitely patient not having respiratory problem, not having respiratory cough, sputum production. So we are not suspecting a chest infection. So what we are suspecting, the patient with high counts with fever, definitely we are suspecting it could be a bloodstream infection that can be related with the central venous line. So if we are suspecting the bloodstream infection and patient is not improving with the broad spectrum antibiotic and we are not able to get anything in the culture, we should suspect candida. So candida commonly causes candidemia and intra-abdominal infection. So my usual practice to teach my resident, at least when you are think about fungal infection, if there's a chest infection or sinus infection, think about Aspergillus and mucor. If you are thinking bloodstream infection and intra-abdominal infection, think about candida. So we'll see in our case what we can able to satisfy these all three features or not. So what are the common risk factors of invasive candidiasis? There are a lot of risk factors for invasive candidiasis, and most important risk factor, which is intrinsic risk factor, is colonization with candida, which is very, very common and which is mostly seen if a patient is hospitalized for long term in a basically in the ICU. Diabetes, GI perforation, because gut is the common colonizer for candida, and GI perforation lead to the spillage over of candida in the abdomen that lead to the intra-abdominal infection and later then lead to the candidemia. Increased age, pancreatitis, and sepsis. Other risk factor are patients on central venous catheter, patients on hemodialysis, patients already received broad spectrum antibiotic. I think it is one of the important risk factor which we can see in Aspergillus and mucor also. Patients underwent for GI surgeries and major abdominal surgeries. Patients on mechanical ventilator for long-term stay with the various line. Patients receiving total parental nutrition, and even neutropenia. Definitely, neutropenia is one of the important risk factor in Candida. But if we have to think, if patients, all the patients have many of the common risk factors, but then you have to think what is the clinical syndrome which presenting with to you, so you can suspect which type of fungal infection. So what are the common invasive Candida infection that can present? Could be candidemia, or we can say bloodstream infection, intra-abdominal infections. These are the most common, but endophthalmitis, arthritis, rarely infective endocarditis can be there. And very, very important to remember that candida rarely causes pneumonia. And isolation of this candida from respiratory sample is mostly colonizing, and rarely we can think that candida is causing pneumonia. So when you think a pneumonia with a fungal infection, think about Aspergillus and mucor. If you are thinking intra-abdominal or bloodstream infection with fungal infection, think about candida. So what are the role of various scoring system and biomarkers like we discussed galactomannan? However, there is no specific biomarker for mucormycosis. Uh, so we have, but in the Aspergillus, we discuss about galactomannan, and there are some scoring system we can utilize, or biomarker we can utilize when you are suspecting the candida. So these are the three common things which I used to use in my practice: Candida colonization index, Candida score, and beta D glucan. So what is Candida colonization index? So Candida colonization index is basically it is a ratio of number of site is colonized upon number of site is cultured. So higher the Candida colonization index, the higher the chances that patients may have invasive candidiosis. This is one of the indicator, not absolute diagnostic factor. And second is Candida score. Candida score has some component like patient having severe sepsis, patient on TPN, patient underwent major surgery, especially the abdominal surgery, and patients with multifocal colonization, which we can see in the in Candida colonization index also, or in clinical practice you can see oral thrust, you can see the axillary culture, you can see the urinary culture, respiratory culture, respiratory samples. If we see, that can be considered as the multifocal various sites to be colonized. So if we can able to satisfy more than three, you can see the incidence rate of candidemia is around 60 to 16 to 20%. So if patients having higher candida score, that could be a chance patient is suffering from candidemia. And third, third is beta D glucan. Again, beta D glucan is a pan fungal marker, which is also a component of almost all fungus. And the level of beta D glucan can be increased in a patient of candidemia or intra abdominal candidiasis. But again, absolutely, it is not a diagnostic test. It is one of the marker. So which one is best? If you see Candida colonization index, Candida score, or beta D glucan, which one is more better? You can see. You can go and read this empiricus sorry, empiricus trial, in which they have categorized the patient with empirical and preemptive therapy as a antifungal micafungin. So they used to see the host factor. Host factor, as we have discussed, patients on CVC, patient on ventilator, patients having bloodstream infection, patients having on-board antibiotic, which is not improving. So in the host factor, you are thinking it could be a candida infection. And you want to start the treatment, and you are thinking a bloodstream infection or intra-abdominal infection, so you want to start the treatment. So which score you can see? So they done a randomized control trial and they categorize the patient. Either you can start on the basis of simple score, or you can start on the basis of beta D glucan guided therapy. And what they found there's no difference in the outcome if you give the micafungin, which is based on either the score or based on this beta D glucan level. So what I want to say that the clinical suspicion in the form of host factor and the clinical syndrome in the form of candidemia or intra-abdominal candidiasis, if we are thinking, then you can start the patient on empirical micafungin. But what is the gold standard for diagnose this candida infection is definitely the blood culture. So some of the guidelines says if your patient has invasive candidiasis, you are thinking you can look for candida colonization index, you can look for candida score and some predictive score, which is almost similar. And if patient having all these three, start the patient with antifungal therapy, send appropriate cultures, and you can send the beta glucan. But these are the flow chart which is given by Indian expert, that if you are looking to the patient in the ICU with these host risk factors and the beta D glucan is available, because the availability of beta D glucan is not everywhere, it is a quite costly test. You can use two serial beta D glucan tests. If both are positive, then only you can start on antifungal. If these are not available, then definitely we have to rely on these scores which we have discussed. And if patient is improved after antifungal therapy of 72 hours, yes, you have to continue. If patient is not improving after 72 hours of micafungin, even with the high score, I think you have to rule out other diagnosis than suspecting the candidemia. So, at the nutshell, what I can say, the Candida score, the Candida colonization index, the beta D glucan, all these are very good negative predictive value test. These are not a test for diagnosis. These are basically the test to rule out. If candida score is low, beta D glucan level is low, you can say patient is not suffering from candidemia. But if candida score is high, beta D glucan is high, that doesn't suggest that patient is suffering from candidemia. You have to have a wise clinical decision. And definitely the culture is the only gold standard. And we used to see the candida in our routine blood culture also, in specific fungal culture also, and the sensitivity is definitely low. It is not more than 50%. Definitely the specificity is almost 100%. So we again come to our patient having diabetes, patient is on CVC, patient is having CLD and already on broad spectrum antibiotic. And what syndrome we are suspecting? It is bloodstream infection, and in blood culture we got candida visvanathi. So we can say that our patient is suffering from candidemia. But I would like to highlight something, especially for the galactomannan and beta glucan, because I used to cover what are the practical approach to diagnose Aspergillus, mucor, or Candida. I'm not going in the detail of these fungal biomarkers, but these fungal biomarkers are not a single test to diagnose. These are one of the component of the microbiological or mycological criteria. So if you see the raised Aspergillus, galactomannan, or beta glucan level, think about the clinical syndrome, think about the risk factor. Do not directly jump onto the therapy. And even positive test, you must take in consideration there are the list of the factor that can lead to the false positive galactomannan as well as false positive beta D glucan. So you can see various antibiotics, various blood products, IVIGs, some other fungal infections can lead to the false positive galactomannan. Especially you would look when we are looking for the ball galactomannan, there are a lot of causes. That could be a contamination in the vial, there could be a contamination in the lab. So you have to judge or interpret these tests very carefully. And there's a similar list also there for the galactomannan. There are some drugs, some bacteria, there are dialysis, the dialysis membrane, and there is so on causes that can cause false beta D glucan level. So you have to judge very carefully these biomarkers. So they are not definitive test like you can say in the MP card is positive for the malaria, the IgM or NS1 is positive for the dengue. You have to look very carefully with these tests with the appropriate clinical syndrome with the appropriate host factor. So at the end, what I want to say that uh, when you are thinking, when you are suspecting that my patient may suffering from invasive fungal infection, basically these ubiquitous like Aspergillus, mucor, and Candida, I have to think a patient is important. I have to see all these three. I have to first look for host factor. Is our is our patients having that risk factor? Is it patient having typical risk factor or patients having some non-neutropenic risk factor? Then I have to think, is it chest infection or sinus infection, or is it abdominal infection, or it is a bloodstream infection? And then I have to send appropriate mycological test. I will try to rule out what are the common causes like bacterial and tuberculosis in the chest infection and routine uh,
Fahad, please mute in mute mode. Please, Fahad. Fahad Alfan. Fahad Alfan, please put in the mute mode. Unmute. Mute yourself.
So in the mycological evidence, I have to rule out common infection like bacterial, some drug resistance bacterial or tubercular infection. And then I can jump on these microbiological investigations like direct microscopy, galactomannan levels, both in the bile and the serum, and PCRs. So with all these combinations, then I could say, okay, yes, my patient is suffering from invasive fungal infection. So I end my talk with this, and I will thank all of audience for the patience listening, and I would like to answer questions. Thank you.
Uh, I sincerely thank Dr. Deepak Kumar for doing a wonderful presentations. Already a lot of questions has come in the chat box, and most of the things you covered in your talk itself. People who listen to the talk, people are asking about mostly about the Galactoman and beta glucan, how to interpret. So we'll start the Q&A slightly later. So I'll ask now post-test questions because he covered how to approach a fungal infections, that two common fungal infections, because we are not seeing very rare common practice. Common infections like Candida, aspergillosis, mucormycosis, and common tests also he touched upon it. What are all the tests we are using and what are all the limitations of the test also he clearly focused, and a lot of question is there. So we start the posters right now. Meantime, you can read the chat box questions so we can have a Q&A at another 10 minutes time.
Yes, sir.
Ben, can you start sharing our slides? My
Yes, sure.
associate joined there. Yeah. Ben, start sharing our slides.
Sir, should I share?
No, Ben, my
Okay,
associate
sir.
is there.
Okay, sir.
He's there.
Yeah.
Okay. We'll have a couple of posters questions to check whether they got the points or not. That's why we are on. Ben,
Sir, one second, sir. One second.
yeah. Okay, meantime, you start loading the questions. I'll ask one of the common questions they're asking about what is the role of urine candida in the urine.
Yes, again, Candida can cause urinary tract infection, but it is common colonizer of urinary tract, and we are used to see very commonly see that Candida positive in urine. So again, you have to look very carefully, look to the host factor. Is patient having clinical features of UTI? Is patients on indwelling catheter? Then just removal of the catheter can be sufficient. And if patient is suffering from, you are thinking it could be intra-abdominal, it could be a candidemia, then you can see the Candida. So what I can say, it's very careful. Rarely, the candida is actually causing UTI. You should very careful to interpret the patients. It's again lung as well as the urine. This is a common colonizer area, and it's not you have to treat every positive culture report of urine in the candida.
When can you share properly there? It's not visible to properly there.
Sir, is it okay, sir?
You're, no, it's not visible. Stop sharing and resharing again in there.
Okay, sir.
Showing bits and pieces only. So the next question about the galactomannan, they're asking about the PCR test. Why the PCRs are going false positive? Why the PCRs are false positive?
Yes, I think it is a very good question. As we have discussed that, so I started my first with that ubiquitous fungus, and these fungal are very common in the environment. So environmental contamination, lab contamination, sample contamination. So these are the common contamination can be there. So PCR, even positive PCR, doesn't suggest that patient is suffering from disease. So if patient having host factor and clinical factor with the two positive PCR, then we can consider, yes, it could be considered. So it is not in one test you can diagnose that yes, it's patient suffering from invasive fungal infection. And the common problem is, I think contamination is the commonest problem, which can be at from sample collection to the laboratory. It can be at any part.
Then for the first question, they're asking about the role of Aspergillus IgM.
Yes, it is a very good question. So I initially I have depicted a very good picture that based on the host, aspergillus can cause disease. If patient is neutropenic or immunocompromised, it causes invasive pulmonary aspergillosis. If patients having hyperacute immunity, then cause allergic bronchopulmonary aspergillosis. But if patients having good immunity, with normal immunity, with some lung problem, that cause chronic pulmonary aspergillosis. So in the common in the simple words, if patient is immunocompromised, the antigen is present, so we used to see the galactomannan. If patient having normal immunity, we used to see the antibody. So IgG of aspergillus is used to diagnose a chronic pulmonary aspergillosis, which is mostly present in a patient with normal immune system but some pre-existing lung problem. Mostly these patients having 3 to 4 months history of fever, cough, sputum, and weight loss. They have already received multiple antitubercular treatment and not improving. So it is a test to diagnose chronic pulmonary aspergillosis, not invasive pulmonary aspergillosis. So yes, but IgM suggests patient has good immunity. So it's a case of CPA.
Yes, usually for invasive fungal infections, we don't use the IgM serologist. This is for allergic pulmonary aspergillosis or past infections we can able to find out. When your slides are visible now, smooth this next slide. So this is a post test for the people who attended and catch the point. So this is a 47-year-old male, basically transplant in 2000. Following post-renal transplant, now presented to you with a history of fever, shortness of breath, and chest pain. He got hemoptysis of 10 days durations. Initially suspected 6 months back. This has happened in 2010. Now it's almost 2025. So uh, when the person has got suspected rejection, so they given pulse doses of methylprednisolone. Pulse doses of methylprednisolone. Now they started antibiotic amoxicillin clavulanic acid. So this is a CT imaging picture. Next slide, please. And he's taking tacrolimus, mycophenolate, and prednisolone. So, what is your diagnosis? I like the participants to put the answers so that we need to check what is your diagnosis here. This one is an easy one. Just check. So, what is your diagnosis now? I want to check the number of people. Almost 90 odd people still participating. So, just go. If you want to get a attendance, please go ahead. People say 2, 3, 4, nocardia, bacterial, and fungal. So mostly fungal because the talk is on fungal. People are asking about it. So okay, I still not get the full scores from all the participants. Those who want to get attendance, please post it. Okay, next slide because we want to think broad. You said fungal infection, that's fine, but what fungal infection is going to cause this problem? Nocardia, Aspergillus, Mucar, Histo, or none of the above, or all of the above? So, what do you think? Now we start answering this question well. People who answered fungal infections, please go ahead and answer. Usually, we don't like infectious disease specialty. We don't like people say fungal infections. People say fungal infections. We don't like it. So we want to be specific. Which fungal? He clearly told in his presentations, Candida, mold, or yeast and mold. That's what we need to differentiate, or sometimes dimorphic. The classification is yeast, mold, and dimorphic fungi. So what do you think here? People are saying this is mucormycosis. People are saying it. Okay. Okay. Next slide. So now I've given answers there. The sputum they're given for Testing. The microbiology lab report this is an aspergillus flavus in the sputum examinations. So what will you do now? How many say I want to start antifungal? People say I want to start voriconazole. I want to start rend the sputum because the last comment is very interesting comment. The specimen is saliva, so repeat the sputum test. So whether you want to rely the saliva specimen going aspergillus flavus post renal transplant with cavitary lesions, or you want to go for a tissue diagnosis or do serum galactomannan. What do you think about it? So people say want to repeat the sputum sample. Please go ahead. People say start antifungal. Whatever thing fungus is growing, cavity is present. The host is a post-renal transplant host. People say they want to start galactomannan. So a lot of things we need to discuss there. So the most important thing in any infectious disease, we need to make a diagnosis. To make a diagnosis of fungal infections, we need to know the host. So this is a host post-renal transplant. A lot of immunosuppressants. Recently also immunosuppressed because of the failure of the transplant. But right now, you're presenting with a cavitatory cap. They tried a decent antibiotic. Despite decent antibiotic, the person is not improving. So the saliva should be the rule is garbage in is garbage out. So if you send a good sample, you can get a good answer. Unfortunately, they send a salivary sample. The microbiology sample lab should be rejected the sample instead of processing it there. Instead of asking for a repeat sample, they should reject it because this is a saliva. So we need to think about these things. Ideal thing, go for a tissue diagnosis. And meantime, waiting for tissue diagnosis, you can start antifungal. That's also fine. So start taking the sample and start empirically after giving a good antibiotic trial. Next slide, Ben. So the diagnosis of fungal infection is a bit challenging. That's what is clearly mentioned. Clinical diagnosis, yes, we can suspect, but it's very difficult to prove the diagnosis by clinically alone. So we need to think about specific diagnosis. Specific diagnosis means histopathology most of the time, not the cultures. Culture growing is fine, but molds are very difficult to grow. Histopathology is a key cornerstone. Sometimes PCRs, but PCRs already we discussed a lot of limitations, a lot of false positivity. This serological test, galactomannan and beta-glucan has got a lot of false negativity. Not false positivity. So we go by negativity value. That is more important. It's got false positivity there. Next slide, Ben. So, for example, the symptoms and signs are very, very non-specific. For example, if you want to find out candida in the blood or candidemia, it's a bit difficult.
मतलब
That's
आप
why
डलेगा
people are,
केला मगर
please,
ठंडा
please
होके
mute,
बनता है
please
लेकिन
mute.
ऐसे नहीं बनता
Abhilasha,
है
Abhilasha,
तो
please mute. All the participants, please mute. So the symptoms is very difficult. The symptoms is very difficult. You can't say this is specific for fungal infections. Next slide, Ben. The specificity is good. Certain markers like fungal endophthalmitis, certain skin lesions, these are all specific but not reliable always. These are all very good specificity, but the sensitivity is lacking. Next slide, please. We already discussed about galactomannan role and beta-glucan. I don't want to discuss the thing. Serological test has got good negative predictive value. If it is negative, rules out infections. Positive may not. Next slide. So this is my last case for your posters. Farmer, road traffic accident, no comorbid, but his alcohol consumptions, agricultural job, farming job. Sustained road traffic accident, apply some native form of treatment. Some leaves he applied, but now the lesion is not healing. What do you think? How many say this person has got candida? How many say this person has got histo, aspergillus, mucor? But mucormycosis, people know always diabetic is not a diabetic, except alcoholism is diabetic, not diabetic. So we need to think when to think fungal infections. Always host is playing a role. So people are saying four mucor. Some people say this is pseudosporium. Yes, pseudosporium means any drowning happened here. Okay, one candidiasis never. Okay, go back. Next slide. Next slide. Sorry. So despite the person was receiving meropenem, clindamycins, and voriconazole, the swelling is keep increasing, and the lesion is also progressing. What is your diagnosis? I didn't give any choice. Now you need to type your choice. What's your diagnosis here? Okay, good. People start mucor and mucor is coming up. Good. Others, those who want to get the attendance, please type. 90 people are there. Still, go ahead. Okay, next slide, please. Next slide. Yeah. So despite the person is not willing for surgery, started IV amphotericin B, what is the reason for failure? Here the diagnosis is not correct or not the correct drug, not the correct dose, not debrided or all of the above. Just go ahead. the person is not improving with appropriate antibiotic. Amphotericin B, Dr. Deepak said, it's a broad one, cover most of the fungus. It has got very, very narrow hole. Most of the things is covered, otherwise it's very few organisms. So people say after debridement. In infectious disease principle, not only start treating antibiotics, we need to do the source control. Whether it's fungus or bacteria or anything, we need to do the source control. That is most important thing. Next slide, please. So mucormycosis, don't think the person actually diabetic, transplant or post. Sometime, even with road traffic accidents, IM injections, lot of injections, contaminated injections can transmit into mucormycosis. This is our own study. Next slide, please. Next slide. Yeah. So the spectrum we need to know, despite the person receiving voriconazole, but still the person has got lesion is progressing, either because of the poor source control or poor drug choice. The clue is aspergillosis because mucormycosis, road traffic accident, native form of treatment, chronic alcoholism, and sustained road traffic incident. Voriconazole is not improving, surgically not debrided. So this is a spectrum. Next slide, please. So the approach we need to know whether we need to give prophylaxis, whether we need to give preemptive therapy or empirical therapy or definite therapy. These are all the four modalities. We clearly touched upon all these things. So this is how we need to approach fungal infections in a practice. So next slide, please. Some of the questions also asked upon this one, we'll discuss it right. Those who want to learn more, the ID algorithms we discussed a couple of months back. Those who are interested, we can provide these books. You can write to us. Next slide, please. Those who want to join and learn more also, this is a QR code, scan, fill the form or send message to us so that we can learn it. I'll ask now, the process is over. Deepak, one interesting question they're asking us. So when we got a resource limited setting, we don't have tests to do beta D-glucan, galactomannan, PCRs, cultures is also not available. Can I start empirical therapy if the person is not improving on antibiotics? What is your call?
Correct. If you want to this answering yes or no, then definitely we should not very much aggressive in empirical therapy, but it depends on the patients. If you are patient in the ICU and on lines and we are suspecting candidemia, then yes, in candidemia we can go upfront with the empirical antifungal therapy. Echinocandins can be given. But if it's patient suffering from patient not having patient having neutropenic risk factors and the CT findings suggestive of halo and reverse halo sign, and we do not have the galactomannan and beta D-glucan, yes, we can give the amphotericin because that's going to cover aspergillus and mucor both. So we have to decide on the case-to-case basis. But like in a patient in the medicine ward not having typical risk factors, the CT is also not suggestive of the typical halo, reverse halo, then we have to investigate the patients rather on starting on empirical antibiotic therapy. So we must have
Excellent.
patient to
I
patient.
agree with Dr. Deepak Kumar. So usually fungal infections, most of the time, even in advanced centers, we start empirically because the diagnosis is a bit difficult. We can think about it, but proving, for example, a lot of tests has got a lot of limitations. Except the histopathology, the proven diagnosis is not going to happen. But we need to try to prove the diagnosis as much as possible. But if you want to start, yes, but after excluding common things, think about fungus, you can start about it there. The next question is common questions. Candida in the lung, for example, fungal hyphase or fungal candida in the lung, or even in immunocompromised patients, it doesn't require any treatment. Candida in the lung or candida in the ET secretions, what is your call?
Yes, sir. Definitely, this is colonization. Do not treat the candida in lung. It's very, very rarely causes the lung infection. Only patients having candidemia, then it could be present in the lung. So, if patient is not satisfying with the risk factor and as well as the clinical sign, I think do not treat the candida in the lung. That should be the
Yeah,
message should be
for
clear.
practical reasons, when you find, for example, in ICU and the ET secretions, bowel secretions growing candida, don't treat it.
Should not.
Candida in the lung never causes pneumonia for practical reasons, except few exceptions. The immunocompromised people put, but even immunocompromised, very advanced immunocompromised, for example, lung transplant setting, yes, or the person has got bone marrow transplant after the failure, graft versus host disease, a lot of immunosuppression should go on. Otherwise, don't treat candida in the lung. The other question is galactomannan can detect for all species of aspergillus.
Galactomannan is yes, it can be positive in other species also, and also in other fungus also, which I have discussed. I think it's not an specific, very much specific for Aspergillus. It can be in other fungus also. So it is not a single test to diagnose. Yes, and there's a lot of limitations which we have discussed, sir.
So galactomannan is usually for Aspergillus specific. Some of the Aspergillus species rarely, for example, Aspergillus nidulans, the pickup rate is very low. Otherwise, most of the Aspergillus galactomannan will positive there. They are asking about why the iron infusions in mucor, iron infusion is a risk factor for mucormycosis.
Sir, can you repeat? What is the risk factor?
Iron infusion, iron.
Iron
Ferrous.
infusion. So iron is if you see the mechanism, the iron is act as a chelating agent, and it increases the growth of a mucor. If you see the pathophysiology, it increases the growth of mucormycosis. So it is advised that the iron should not be given when we are suspecting mucormycosis. It increases the growth of mucormycosis because
So
of
usually iron is a
but
good source for
but
the fungus. Correct.
yeah,
Go ahead.
but iron chelation is helpful to treat. No, there's no proven data that iron chelation can help to treat a case of mucormycosis.
And one more question is, what is how the BTKI, that's butyrosine tyrosine kinase inhibitors, brutonine tyrosine kinase inhibitor can cause mucormycosis?
Bruton tyrosine kinase is, I think it is one of the biggest risk factor. Sir, I could not able to explain the exact mechanism because I'm not
Usually
remembering
it
that.
suppresses the macrophage functions, it suppresses the neutrophil functions. So ibrutinib like
Basic the
CML thing.
major defect is neutrophil
Yeah,
problem
correct,
is
sir.
there. Yeah.
So it compresses the immune system. One
Yeah.
case scenario they put 35-year-old female, uncontrolled diabetic, they develop pansinusitis. On debridement, every time the tissue is growing, one is aspergillus fumigatus, next time aspergillus species, third time mucormycosis. Serum galactomannan is negative. Received 30 days of liposomal amphotericin B. Now on posaconazole. How to interpret these culture findings and decisions on further treatment, POSA or worry?
Especially when we are dealing with the rhino-orbitocerebral mucormycosis, definitely if there's a multiple fungal infection and there's a mucor, then I will going to give amphotericin and POSA because that will going to cover aspergillus also. But here the radiology is very, very important. What is the radiology saying? Is it saying the invasion is there, it is increasing or decreasing? Then we can decide. But definitely I will go with the POSA because mucor is there, then POSA will going to cover aspergillus and mucor both.
This is most important. Tissue is growing. That's most important. Sometimes rarely polymicrobial malignant otitis externa with pansinusitis is possible, or even invasive sinusoidal infections. Mucor can happen, particularly in a poorly controlled diabetic is possible. One more question they're asking: can we give andulafungin in a septic shock patients in ICU with triple vasopressor support? Where source is not known. They do not identify the source, but triple vasopressors. Can I start andulafungin? Specifically, they are asking about anidula.
It's not that only anidula, we can give any kind of candidates if we are suspecting that could be a candidemia. If patients is more than 5 days of ventilator, patients with many of the lines, patients already on broad spectrum antibiotics and not improving with these antibiotics. And we are looking if we can easily see the oral thrust, if oral thrust is present, if there's a candida colonization is present, we have to look patient as a whole and then we can start. But it is not that only anidula. We can start caspo, we can start any of the kind of candidates which is available. And after 72 hours, we have to again check the patient. We have to send beta-glucan if it is available. If the patient is not improving, then think about other infection rather than the candida.
Couple more questions to wind up there.
Yes.
Any role of AG ratio reversal in fungal infection diagnosis?
AG reversal is basically not in a specifically for the fungus. This is basically albumin is a acute negative acute phase reactant we used to decrease in any of the acute or some chronic infection. So it's not specific, but it suggests there is some inflammation is ongoing.
And one more interesting question is the last question I posed to you there. People with HIV, CD4 count of 150, no respiratory symptoms, CT thorax, left lower lobe cavity lesions, TB workup negative, lung tissue histopathology, yeast intracellular, serum cryptococcal antigen 1 in 256, MRI brain and CSF normal. How to manage this patient?
Cavity in a patients of HIV, definitely it is not an HIV is not a condition of neutropenia, so it is not a risk factor for aspergillus and mucor. So if a cavity in HIV, yes, first is TB, second is histoplasma, which is quite common. If you think a fungal infection in a HIV with lung infection, yes, you have to rule out the histoplasma, which is one of the common fungal infection can be there. Then third is cryptococoma can be there. Then we have to go for the ball and we can send appropriate investigation and culture.
Excellent. Usually, cryptococcus in the CD4 count is less than 100 is possible. That's why the guidelines and the CD4 count is less than 100. We screen with serum cryptococcal antigen. 150, yes, technically the chances are a bit low. As he rightly pointed out, think about other diagnoses more common, like histo is more common compared to crypto. But you got cryptococcus means, suppose because it's a PLHA, we do not know. We need to check the CD4 count again one more time. If it is still suggestive of it and your diagnosis is still cryptococcus, because cryptococcal antigen also remain positive for longer time also. So it's a bit difficult. The person has got previous cryptococcus remaining positive, and this is a new lesion. Think about it. A CD4 count of 150 is slightly less for cryptococcal, but your diagnosis is not, no other diagnosis is made. Then if you want to treat, yes, you can treat because it's easy to treat also. So people keep on putting the questions right now. So since we are at 8:30, I test for detecting histoplasma so good. Usually histoplasma antigen is available right now. I sincerely thank all the participants and thank the speaker keeping all the participants still at the end and answering all the questions and very good presentations. A lot of appreciation come from the participants. It's excellent presentations. You confirmed whatever diagnosis needed for MDPGs to tackle the common fungal infections they encounter in the daily practice and try to summarize in a nutshell there. I also thank the AP and ICP for giving this wonderful opportunity. I thank all the participants, but this is always says this is the beginning. 130 minutes or 40 minutes, you are not going to learn the fungal infections. You need to study about it for the next week, and your exams are coming shortly. So prepare for exams also. So I conclude the sessions. Thank you one and all. Thank you, Dr. Deepak, for accepting our invitations and doing excellent presentation there.
Thank you, sir. Thank you very much, sir, and thank you all participants.
Thank you, sir.